Hi everyone, thank you for tuning into today's MDH Stroke Program monthly webinar. Today's topic is a review of the NIH Stroke Scale. I'm now going to turn it over to Nikki Anderson, Stroke System Nurse Specialist.
Great, thank you Michelle, and welcome everybody. Thanks again for joining us today for the Minnesota Stroke Program monthly webinar, a review of the NIH Stroke Scale. I'm Nikki Anderson, as many of you already know, and I'm the Stroke System Nurse Specialist for the Minnesota Stroke Program. When deciding a clinical topic for today's webinar, we looked through previous evaluation results. A common topic we discovered was the NIH Stroke Scale. So hopefully you'll find this information useful. We do value your feedback, as it not only helps us to improve what we do, but it also enables us to tailor our offerings to you as our audience. At the conclusion of the content, we will put a direct link to the evaluation in the chat, and I will also send it in a follow-up email. Please take a few moments to complete the evaluation. Good news, you will also receive 0.5 contact hour certificate for participation in today's webinar at the completion of the evaluation. I'll be covering a lot of content in the 30-minute time slot and have to move rather quickly. We still want you to ask questions by typing them in the chat. There's instructions for how to do so here on this slide. My colleagues, Allie and Michelle, are both with me today, and we'll be keeping track of these questions. I do plan to answer any questions that come in a follow-up email. Today, we are going to review the NIH Stroke Scale purpose and history, the individual elements and tips for scoring, the resources available for NIH Stroke Scale certification and training, and references I used to develop the content today are also included in this slide deck. Here are the objectives for today. Upon completion of this webinar, learners should be able to describe the NIH Stroke Scale purpose and use in care of acute stroke patients, explain the rules for scoring the NIH Stroke Scale, and describe 2 tips for scoring difficult or confused patients. All right, let's get started. The next few slides will cover the purpose, design, history, use, and documentation of the NIH Stroke Scale. So what is the NIH Stroke Scale? It is a widely used systematic assessment tool designed to measure neurological deficits. The severity of stroke ranges from 0 to 42. The goal is to have multiple examiners at different sites score similarly. It contains 11 elements related to specific function. The higher the total number, the higher the impairment. The scale is intended to be reproducible. It does have its flaws, though, and does not accurately reflect gait impairment, cortical sensory function, distal motor function, memory, or cognition. Get this, though. That design was completely intentional. It allows non-neurologists to perform the exam. The NIH Stroke Scale we know today evolved from another larger scale used in previous studies. The NINDS trial is where the NIH Stroke Scale that we know today was born. After this trial, it became the gold standard for stroke severity rating. Certification was created to facilitate wider use of the scale outside of research. The NIH Stroke Scale itself is a brief, reliable, directed exam. It helps to determine appropriate treatment. It also provides a method to track changes over time and ultimately gives us a common language as providers to communicate the patient's neurological status. It is used as a severity tool that helps to predict patient outcomes. Scores ranging from 1 to 4 are considered mild, 5 to 14 are mild to moderately severe, 15 to 24 are considered severe, and greater than 25 are very severe. As you can see here on this slide, an NIH Stroke Scale of greater than 16 has a high probability of death or severe disability, whereas an NIH Stroke Scale of less than 6 has a higher likelihood of a good recovery. An update to the 2018 Acute Ischemic Stroke Guidelines was released online this month, and Al also included a link to access the guidelines in his monthly email. Here's a quick snapshot of where the NIH Stroke Scale fits into the guidelines, stating that the use of a stroke severity rating scale, preferably the NIH Stroke Scale, is recommended. As far as documentation goes for the NIH Stroke Scale, it is to be completed during the initial evaluation. Now, who completes the assessment varies from location to location, even across our designated primary and comprehensive stroke centers. There are even more performance measures related to the NIH Stroke Scale for higher levels of designation. Certification is recommended through the use of NIH Stroke Scale training videos. Practice does make perfect, right? As far as the registry goes, there is an element included that most of you are familiar with, which is indicate if the NIH Stroke Scale assessment was performed at this hospital by a physician or nursing during the patient's initial evaluation or within 48 hours of the patient's arrival date and time. Now, the 48 hours was written in order to allow hospitals a longer period of time to conduct and record an NIH Stroke Scale in order to establish a baseline level of severity for the purpose of helping to predict patient outcomes and changes in functional status. Now that we've reviewed the background for the NIH Stroke Scale, next I'll review some of the rules and share a resource for difficult scoring. Again, please don't worry if you get called away to a stroke alert or have to attend to something else. Today's webinar will be recorded and shared with all of you, and I will respond to the questions that come in a follow-up email. The NIH Stroke Scale rules are to administer the assessment in numerical order. Results should be recorded immediately, especially prior to treatment. I bolded the next rule as it's kind of the golden rule for scoring. Score what you see, not what you think you should see. Score the first response for most of the elements. Minimize your coaching. Some items are scored only if definitely present. For example, ataxia is scored as absent in the patient with hemiplegia because it's not definitely present at the time of exam. And lastly, for those difficult to evaluate patients, there are some techniques that may be used to score. Here's a great resource from the AHA. The link is included here on the left side of the slide. There's also a table shown here that lists each of the scale items, what to score for coma, difficult or confused, and then also some nice tips for scoring. Some of these tips I've included in the rest of the presentation today. Now for scoring the aphasic or confused patient, it's okay to use pantomime, which means to gesture without speech. For example, when asked, "Show me your teeth," you can also demonstrate that for the patient. And I'm pretty certain when I did this, I looked like Voldemort, pictured here, from Harry Potter. Now we'll walk through all of the NIH Stroke Scale elements, the pathophysiology involved, and tips for scoring. First element of the scale is level of consciousness. It contains 3 sub-elements, A, B, and C. Stroke patients with a decreased level of consciousness can indicate clinical deterioration. There may be metabolic causes, such as hypoxia, organ failure, infections, toxins, and also ischemia. There also may be structural causes, such as injury, masses, or cerebral edema. For the first element of level of consciousness, 1A, ask the patient 2 to 3 general questions about the circumstances of their current situation. You can't skip scoring any of the elements, so you must choose a response, even if obstacles such as an endotracheal tube, language barrier, or trauma are present. To score a 1, the patient would be drowsy, not really alert, but arousable by minor stimulation. To score a 2, the patient wouldn't really be alert. They would require repeated stimulation to arouse them, which may need to be painful. A 3 is only scored if a patient makes no movement other than reflexive posturing in response to noxious stimuli. You're usually able to score this one by your initial greeting. For the second sub-element of level of consciousness, 1B, this is assessing orientation. There are 2 questions involved. Ask the patient the month and their current age. The answers must be correct and no partial credit can be given. Other questions are not asked here as this is a standardized assessment. So those 2 questions are the only ones to be asked. Scoring for the aphasic patient and stuporous patient is a 2. Unable to speak because of an endotracheal tube, trauma, severe dysarthria, a language barrier would score a 1. A tip for scoring this element, score the initial response, and patients may actually write the answer if they're unable to speak. The last sub-element for level of consciousness is commands, 1C. Ask the patient to open and close your eyes. Grip and release their non-paretic hand. You may substitute another one-step command if the hands are not usable. Only score the first attempt. It's okay if they are impaired by weakness. They should receive credit for trying. And remember, this element is assessing for following commands. Now, if they do not respond to the command, you can use pantomime here. Another thing to remember is you are not testing grip strength, just the ability to complete the task. The next element, number 2, is best gaze. Best gaze evaluates for extraocular movements. Abnormal findings may indicate pathophysiology in the frontal lobe, cerebellar, vestibular dysfunction, or dysfunction of the cerebral cortex. For some MCA strokes, the eye will actually go towards the lesion. This element is only testing horizontal gaze. Have the patient follow your finger with their eyes from right to left without moving their head. If the patient does not understand, establish eye contact and move your face from left to right. Unresponsive patients can be scored using the doll eyes maneuver. This is an exception to the first observable response rule. The third element of the NIH Stroke Scale is visual. Findings of this item in stroke patients usually arise from a lesion of the optic radiations or occipital lobe. For testing of visual fields, you want to test the upper and lower quadrants of each eye. In the training videos, some of the examiners use finger wiggling and others use counting of digits. In this item, we seek to demonstrate normal visual fields, not their counting ability or refractive error, but it is okay to use both methods. A score of 3 is reserved for blindness of any cause in both eyes. A 2 is for loss of vision for 1/2 of the visual field of one or both eyes. 1 is for partial loss in a quadrant. Visual fields can be tested by threat, and if the patient is struggling with communication, they can also point to the site of movement. Next is facial palsy. You are to assess the muscles of facial expression supplied by the facial nerve. Findings may indicate a lower motor neuron lesion of the facial nerve. And as a reminder, facial asymmetry can often be seen in stroke and can be the first clue to dysphasia. For facial palsy, you can ask or use pantomime to show me your teeth, raise your eyebrows, open and close your eyes. If the patient is confused or nonverbal, use noxious stimuli to elicit a grimace. The next 2 elements are related to the motor function of the arms and legs on both sides. Abnormalities found here are related to lesions of the motor cortex or corticospinal tract, contralateral to the side affected. For scoring the motor function of the arms and legs, each limb must be tested separately. Have them raise their arms straight out with palms down to a count of 10. Count out loud. You can help place the limb into the preferred position. An initial dip of the limb is allowed, and you only score drift if it occurs after that initial dip. If there is no drift for the full 10 seconds, the score will be a 0. If there is a drift downward without touching the surface, that's a 1. If they drop to the bed before the count is up, that's a 2. If some movement is seen, but the patient can't really lift or hold, that's a 3. And for no movement or the limb is flaccid, score a 4. This is only untestable with an amputation or fusion. If they are confused, you can use pantomime gestures to try to help the patient follow what you are asking them to do. We have often encountered patients with arthritis and joint pain, and when this happens, use your best judgment for scoring. For scoring the legs, again, check one at a time. Have them elevate their leg and hold for a count of 5. Scoring is the same as motor function for the arms, except again, the count is only for 5 seconds. You may also help to raise the leg for this one. The next element, number 7, limb ataxia, examines coordination of movements. A weak extremity can appear poorly coordinated. This element is only scored if ataxia or poorly coordinated movements are present that are unrelated to weakness noted in motor function. Abnormalities here may indicate a posterior circulation stroke, specifically the cerebellum or connection to the brainstem. For testing, use nose to finger to nose to finger, and heel to shin tests on both sides. A 0 is when ataxia is absent. 1 would be present in one limb. A 2 is scored for present in 2 limbs. Again, this is only scored when present. They will score a 0 if unable to follow directions, and the same thing goes if they are paralyzed. Aphasic patients may actually perform this test normally if you passively move the limb first. Sensory is the next element. Abnormalities seen here can be common in stroke patients and usually indicate lesions or dysfunction in the contralateral thalamus or parietal lobe. For testing, ask the patient, can you feel this? Does it feel the same? Refrain from asking sharper versus duller. Test the arms, legs, trunk, and face. Coma patients are arbitrarily given a 2. A score of 2 is actually pretty rare though. A 1 is for mild to moderate loss. There's difference noted from side to side, but they're aware of being touched. And a 0 is normal, no loss reported. Tips for scoring this element. You can use pinprick and observe reactions if they're unable to cooperate. Withdraw from noxious stimuli in obtunded or aphasic patients as well. Make sure to use bare skin and do not test through their clothing. Language problems are also common in stroke patients. This most commonly occurs in the Broca area, Wernicke area, frontal, parietal occipital areas of the left hemisphere. Fun fact, a small number of people have language function located on the right side of the brain. Now, before we discuss testing of this element, I thought it would be good to review aphasia types. Non-fluent or expressive aphasia is indicative of damage near the left frontal area of the brain or within Broca's area, which would also be called Broca's aphasia. With this type, patients will struggle to get words out. They can usually understand what others say, and they're aware of their difficulty in communicating. When patients were faced with this, it really always pulled at my heartstrings as a bedside nurse. You can see the pain and frustration in their face when they're trying to communicate, and they understand you when you're talking to them. Fluent aphasia, or receptive aphasia, is when the patient can speak easily and fluently, but they aren't really making sense. This is indicative of damage to the middle left side of the brain or Wernicke area as well. These patients use unnecessary words. They don't usually understand spoken language and aren't aware that others aren't understanding them either. Global aphasia is present when there is extensive damage to the language areas in the brain. This creates severe disability with both expression and comprehension. The NIH Stroke Scale has a set of standardized visuals to use for this element. I'd recommend laminating these sheets and having them handy in your emergency department. You would ask the patient to name items, describe the picture, read the sentences. Please make sure if they wear glasses and if they happen to be with them, that you offer them for this part of the exam. A patient who is mute or has global aphasia would score a 3, and the same thing goes if they are in a coma. A 2 would be for someone with severe aphasia, fragmentary speech, limited to one-word answers, and the burden of communication is on the listener. A 1 is for mild to moderate loss of fluency. They're able to comprehend the general idea. And a 0 is normal fluent speech. For this element, you are evaluating both language and comprehension. Most examiners score this based off previous exam information. The picture sheet, however, is used to confirm their impression. If stuck between a 1 and a 2, use the materials. A patient who misses more than 2/3 of naming objects or are only able to follow a few simple one-step commands would be a 2. This is an exception to the first response rule. Element 10 is dysarthria. This is looking at the quality of speech. Similar pathology here to what we reviewed for the fourth element, facial weakness. You score dysarthria by having the patient read the list of words or repeat. Here, you are evaluating speech clarity. 2 is for near to unintelligible speech, coma, or mute. 1 is for mild to moderate slurring, and a 0 is for clear speech. Listen to their words. If they can't read or have difficulty seeing them, have them repeat you. It's only untestable if they are intubated. The last element of the NIH Stroke Scale is extinction and inattention, formerly known as neglect. This evaluates the contralateral parietal lobe. When present, it creates significant patient safety risks. Sufficient information to identify neglect may be obtained during prior testing. If the patient has a severe visual loss, preventing visual double simultaneous stimulation, and the cutaneous stimuli are normal, the score is normal. If the patient has aphasia but does appear to attend to both sides, the score is normal. The presence of visual spatial neglect or anosognosia may also be taken as evidence of abnormality. Since the abnormality is scored only if present, the item is never untestable. The normal patient would be able to identify stimulation on both sides simultaneously, which would then be a score of 0. There are limitations to the NIH Stroke Scale. It doesn't consider stroke symptoms such as headache, nausea, dizziness, truncal ataxia, hand or foot weakness without proximal weakness, memory loss, or hoarseness. Low NIH Stroke Scale scores may still be disabling and should be considered for treatment. It's best to consult with neurology experts as soon as possible in your process to help decipher eligibility. This table here is from the Inclusion-Exclusion Criteria resource that is available on our website. Other things to consider. Again, consult the neurology experts as soon as possible. They have the clinical training and background to diagnose acute neurological disorders. A full neurological exam should be considered, which would include other things such as pupillary response, gait, eye movements, strength, all of which are not included in the NIH Stroke Scale. NIH Stroke Scale certification is a programmatic decision. What we require of acute stroke-ready hospitals through designation is that all acute stroke team response members, at a minimum, nursing and providers that respond to stroke, receive education 2 times or 2 hours annually. We recommend that staff are knowledgeable in the use of the NIH Stroke Scale. Listed on this slide are some NIH Stroke Scale certification and/or training resources. In July of 2017, the MDH sent training videos to hospitals. You may or may not still have these available for use. We do, however, have a limited amount left over, which we are willing to send directly to you while supplies last. So if you are interested, please email us at our stroke program email, health.stroke@state.mn.us, or you can also email me directly. The AHA Learning Center has certification available, which is free to members and $10 for non-members. Apex Innovations is also a robust educational resource that can be purchased by hospitals and/or health systems. At this time, from what I found, they do have a free training option for NIH Stroke Scale certification listed on their website. I've also listed here 2 NIH Stroke Scale apps I found along the way. But I want you to please note, if you attempt to use any of these sites and encounter any issues, please contact those sites directly, as I don't have much experience with them myself personally. Through this website as well, you can still order the NIH Stroke Scale training videos, and it does appear to be free of cost. Listed here are the references I used to gather content for today. You may also choose to browse through these in your free time and/or use them for future content development. Please complete the evaluation to complete your contact hours to receive your contact hours for today's webinar. Allie has placed a direct link to the evaluation in the chat. If you don't currently see the chat, you can hover your mouse at the bottom of your WebEx screen, and the menu of options should appear. Click on the chat bubble, and the chat box will appear with that direct link located in there. Now, please don't panic if you can't get the chat box to appear. I'll be sending a follow-up email actually in the next few minutes, which also includes the evaluation link in today's slide deck. Once we have the recording available, we will send another email with a link to the recording, and I will answer any questions you sent to us via the chat at that time. Pictured here is the contact hour certificate that you will see upon completion of the evaluation. There are directions located on the site for saving and printing the certificate for your records. Please let us know if you have any issues by contacting us at our stroke program email address, and we would gladly help you out. Again, thanks for tuning in to today's webinar. I hope you all have a great holiday week. Hopefully most of you don't have to work, and please don't eat too much turkey. And reach out to me directly if you have any questions. Thank you so much.